So I know you don't want to go into details, but knowing how the COVID pandemic exacerbated burnout in the healthcare industry, should there be or are there steps that the industry should recognize and start to take to help prevent this from happening again when we know the next pandemic is going to arrive?
Yeah, absolutely, absolutely. So I think when we think about the things to do, it helps to gather data about what some of the causes are. But if anybody's interested in Googling the U.S. Surgeon General's report, the 2022 report on healthcare industry burnout, Dr. Murthy does a really good job of encapsulating the entire ecosystem. So it starts at the kind of societal cultural level and goes into the healthcare system, and then organizational implications like systems and policies, and then leadership, the work unit, and then at the individual level. So there are many, there's a myriad of causes. But what I can say is, and I'm going to do a shameless plug for the latest book from doctors Maslach and Leiter, The Burnout Challenge. They did a really good job of calling out the common themes that are actually actionable by individuals and organizations. So they start with, and I know this won't be a surprise to you because we've talked about this, the unsustainable high workloads.
Right.
Now, of course, if there's a shortage, you know, what are you going to do, right? There are a lot. So some of the creative options out there include using telemedicine when you can, using nurse practitioners when you can. I believe that there are some states that are elevating their nurse practitioner licensing to be able to take on some of the
Right.
workload and some of the roles that physicians have taken on. So to kind of spread the work a little bit. Um, Also, there's still a gross underrepresentation of Black and Brown members of our community in the physician talent pool. So by identifying talent, right, in underrepresented communities, also indigenous peoples as well, to be interested in this work, can help to fortify, the supply, of physicians. Right now the majority are still Caucasian, with the next population Asian in the United States.
Mhm.
Um, the next one that they talk about is insufficient choice and control. So that ranges from everything from what their work hours are, right? So if you're somebody who has said, hey, I put in 3 months ago for my kids, band performance, right? And you now scheduled me the exact time I can't do it. You're now asking me to choose, right? And when you get the, well, sorry, we're short staffed kind of a thing, that has wear and tear, right? And that reduces efficacy. And control, as we said, things like policies that are set without physician input. They're not saying, hey, we shouldn't look at cost cutting. Of course, we need to look at cost cutting. What medical input is part of the decision making about, these different things, about the ways that we're dispensing medications and the exceptions that we're allowed to make. So
Absolutely.
those are the kinds of things. Who's on their medical team, et cetera, et cetera. So the next one is what they call ungratifying rewards and recognition. So I had one physician in my study say to me, I don't need your $100 bonus. I don't even need your $500 bonus. I need time off, right? I need you to stop eating into my vacation time.
Right.
I need you to leave me alone. I don't want to go on a staff retreat and party with people. I want to get away from all you people.
No, the
Right?
work-life balance, you're right. It's absolutely correct.
Yeah.
Yeah.
Yeah. Yeah. And well, by the way, and there were other people who were starved for that kind of connection. So what that basically says, didn't get enough of it, and we're feeling isolated. So what that says is one size doesn't fit all, right? What's rewarding and recognizing for you might not be for me. So that's where, collecting data about your workplace and identifying and providing options and have people opt in. Um, the fourth of the six is an unsupportive work community, right? So some of the findings in my research was, some of the issues associated with how traveling nurses are received within these organizations, right? So traveling nurses, many of whom used to be staff nurses, right, exercised their plan B because they couldn't get the hours that they needed. So they decided to go this route, but now there's resentment because they do make more money.
Right.
They do kind of come in and they're not as vested and they're not as loyal. But at the end of the day, they are part of the team, right? And so while they're part of the team, they're not being oriented and onboarded and given the resources, as if they were a staff person. So how is that person going to be in the OR or in the ER?
Right.
Especially early times, and that's just, again, I'm just giving you examples. There's many examples. The fifth one is dissatisfaction with the norms of fairness and respect and justice. So, and that can be anything from promises for childcare for the younger female physicians who still are working the second shift at home and needing to bear the burden of childcare. Promises not met, so getting that support in any way, especially, by the way, shockingly during COVID. Right. To physicians of color experiencing microaggressions, whether it's from leadership or the team's placement in terms of schedules, et cetera, et cetera. And the last one is the non-alignment of their own values to the meaning of work. So it's how the organization explains meaning in work, which is going to be more about efficiency and cost and compliance. But what are, the organization's values and the physician's meaning of work, which is health promotion, disease prevention and treatment, right? And quality time, for the care of their patients. So the other part that can come into play is when patients and families insist on the dis and misinformation that they're getting from social media, et cetera. So there's a lot of public health mis and disinformation that come into the office and cause families and patients to be hostile and disrespectful and uncooperative. So many physicians have said, hey, you know what, at the beginning of COVID, especially because this got amplified during COVID, I tried to appeal to people, appeal to their logic, appeal to their emotions, but after people just, spewing ugliness, we'll just put it that way, many physicians have just said, look, I will try once. And if they're not in, I'm out. And that's an understandable response, but that's burnout, right? That's burnout.
Absolutely.
Yeah. So I hope that gives you like some winnowing down of some of the issues that are out there.
No question. I think, as I said at the beginning, burnout is not new, but certainly COVID exacerbated the situation. And certainly, as you're talking, it doesn't sound like the reasons for burnout are going to go away, especially in the healthcare industry. So this has been a really important topic for not only the physicians and nurses, allied health professionals, but also the people who run the healthcare systems and make the governmental policies that are going to affect healthcare. So I think this has been a great discussion. Hopefully individuals will realize if they're in that space toward burnout, or they'll figure out what they have to do to help get rid of that potential. I would like to make sure we get some of those references you talked about.
Sure.
Those would be helpful to our audience. And again, just thank you for the time you spent today on a topic that doesn't always get the airplay that it needs.
Thank you.